Hello, I'm Dr. Gerald Chodak. In previous videos, I've discussed the way of lowering the male sex hormone, called testosterone, by doing either a bilateral orchiectomy, a surgical removal, or medical management using an LH-RH agonist. Now, in an earlier video, I also discussed where testosterone is produced. And most of the testosterone in the body comes from the testicles. But a small amount actually comes from the adrenal glands. And so if we do either the surgical castration or we do the injections of the LH-RH agonists, neither of those treatments will affect the testosterone that is coming from the adrenal gland. And so what do we do about that? And is it important to treat that as well? So in the past, a number of studies have been done, good scientific studies, that have shown that those men that get a combination of a treatment to lower testosterone and a treatment to block the remaining hormones coming from the adrenal gland, that combination offers a better survival than men who receive the medical or surgical castration alone. And this has been a very controversial topic over the years. There have been these many studies that are done, and many doctors have varying opinions. The fact remains, the longest survival throughout the world that's ever been reported has been by doing two treatments. The treatment that lowers the testosterone from the testicles and the treatment that blocks the action of the hormones coming from the adrenal gland. That's accomplished using a pill called an anti-androgen. And this drug works, or these drugs work, by blocking the action of the hormones. It prevents the hormones from the adrenal gland or anywhere else. It prevents them from stimulating prostate cancer cells. And so it is something else to consider as part of the overall management of prostate cancer. So this idea of combining the two treatments, treating the testicle hormones and the hormones from the adrenal gland, that treatment is what's called combined androgen blockade, or some people call it maximum androgen blockade. Those are abbreviated as MAB or CAB. And so this treatment is another option for men who are diagnosed with metastatic disease. Now, around the country and even around the world, there's been an ongoing debate. Should we do combined androgen blockade when we first diagnose metastatic disease? Or should we simply do medical or surgical castration and later on, if a patient progresses, then we can add the medications that will block the hormones coming from the adrenal gland? This controversy has raged despite the fact that the best scientific evidence is in support of doing early and continuous combined androgen blockade. We would continue that combination therapy until there is evidence that the cancer has progressed. Most commonly, that's by a change in the PSA level. And if that occurs, the next thing we're going to do is say to you, we're going to stop the drug, the anti-androgen, and see what happens. The reason we're going to do that is because in about half the cases, the stopping of the anti-androgen will lower the PSA level and reduce any prostate cancer symptoms that have occurred. That treatment may not last that long, but it is the standard very first treatment to do after a man has been on complete or combined androgen blockade and their cancer has progressed. So, the option is here, offer a man combined androgen blockade from the outset of the diagnosis of metastatic disease and stay on that therapy until something changes. That would offer you the best chance for survival. Now, that treatment is not for everyone because, of course, there are potential side effects. Those side effects include those men getting the anti-androgen. We have to monitor their liver function tests because in a small percentage of cases, the liver functions can change. The liver enzymes may become abnormal. It's rare, but possible that a man may die depending on which of the various anti-androgens that they receive. So that is one side effect. Another side effect is that a man may develop breast tenderness and breast enlargement. We can block or prevent that from happening in almost all cases by giving a few doses of radiation to the chest, to the breasts. That has almost no complications, and it's easy to do, only takes 2 or 3 treatments to accomplish. But it can reduce the men or prevent the men from getting significant breast enlargement. If radiation is not offered, then about 50 or 60% of the men will get some breast enlargement. Only about 10% are significantly bothered by it, and it is possible to undergo a plastic surgery operation to reduce the breast tissue in those small cases where patients develop bothersome enlargement of their breasts. Nevertheless, I believe that men who are diagnosed with advanced prostate cancer, metastatic disease, should be offered combined androgen blockade. They should be told that the longest survival ever reported was with the combination of therapy rather than with castration alone. So it does offer the longest chance for survival, and it may improve survival by an average of 3 to 6 months. An average. That means that some men will get more than that, some men will get less than that, but when you average it out, it looks like it's an improvement in survival of about 3 to 6 months. Unfortunately, around the country, a lot of doctors don't like that therapy. They don't think that the benefit is big enough to offer it. Bottom line for you as a patient is you certainly ought to discuss it. You certainly ought to know the pros and cons about it. And if someone, or if you ask your patient, doctor, what is the best way to maximize my survival? The answer would be by offering early, continuous combined androgen blockade until there is evidence of progression. Thank you.